Okay. Assalamualaikum warahmatullahi wabarakatuh, and good morning, everyone. Every year on 14th November, we celebrate World Diabetes Day. That was created in 1991 by the International Diabetes Federation as well as the World Health Organization. And 14th November was actually selected due to the birthday of the person who discovered insulin way back in 1922. That is Sir Frederick Banting, who later received a Nobel Prize together with Charles Vest. So this year, as usual, we celebrate World Diabetes Day. And today, what we're going to hear is mainly on the type 1 diabetes. We all heard a lot about type 2 diabetes prevention and treatment during World Diabetes Day celebration, but not so much on type 1 diabetes. So it gives me great pleasure to introduce to you Associate Professor Dr. Azriyanti Anuar Zaini, the head of the Pediatric Endocrine and Diabetes Unit at the Millennium Medical Center since 2016. Prof. Azriyanti, best known as Prof. Yanti, she actually completed her fellowship in pediatric endocrinology at Oxford University together with UMMC after obtaining her master's and MBBS from the Millennium itself. So Prof. Yanti has done a great job over the last 5-6 years, taking over from myself and actually develop further the pediatric endocrine unit after the passing of Professor Fatimah Harun. Professor Fatimah Harun has always been very close to us. So today, Prof. Yanti is going to talk to us on this topic on the evolution of diabetes and knowledge and the evolution, where are we in Malaysia. Prof. Azriyanti.
Okay, thank you very much. Assalamualaikum warahmatullahi wabarakatuh, and a very good morning to all. Thank you, Prof. Yazid, for that very kind introduction. A little bit too much for the first Wednesday morning. Nothing much really from my side. Thank you, Prof. Yazid, for giving me this opportunity to talk about type 1 diabetes in conjunction with World Diabetes Day, which we celebrated last week. Sorry about the sort of like a late announcement on this talk. It was literally a bidan terjun for me. Last minute kena suruh buat presentation. So yes, thank you very much, Prof. Yazid, for this. Anyway, what we're going to do today is just a simple talk, hopefully just to refresh everyone about the importance and the evolution of type 1 diabetes over the years. Like Prof. Yazid said, World Diabetes Day was actually, is to commemorate the person who discovered insulin 100 years ago. And I think it's about time for us to actually, for me to share with all of you today in regards to the new knowledge, hopefully some of the new terms, new management, new findings about type 1 diabetes. The topic itself is extensive, and to be able to deliver this in half an hour is hopefully a miracle. So I'm just going to do my best. Just sit back and enjoy, and just not many notes to really take from this this talk. Is just to enlighten you and to share with you the additional knowledge. All right. Just to start off with there's so many things to talk about type 1 diabetes, but I think what I would like to do today is just to give you back the basic principles of the knowledge, to know what is the the basic principles of type 1 diabetes, perhaps some new findings and over the years, and maybe I'm going to talk a little bit about misdiagnosing type 1 diabetes, evolution in terms of insulin discovery, as well as the monitoring of blood glucose over 100 years. A little bit probably about funding and resources and the other challenges, like for example, psychosocial and support, mental health support for children with type 1 diabetes. Right, so just a basic understanding about type 1 disease, type 1 diabetes, back to core knowledge. It's all about autoimmunity. It's about destruction of the beta cell in the pancreas, causing a relative or an absolute insulin deficiency. So I really like to share this slide of mine to anyone really, from medical students to public as well to professors alike, that a simple illustration goes a long way, hopefully. And this lovely cartoon illustration was drawn for us in our little book of Lina Ada Diabetes from our colleague, an illustrator, Encik Arif. He drew nicely to describe how important it is insulin in our body. Insulin as the key, or what we call the kunci, to allow sugars to be brought into the cells. And without that particular key, there's no insulin, means there's a persistent hyperglycemia causing osmotic diuresis and glycosuria. And eventually over time, and in particular in type 1 diabetes, within 2 to 3 weeks, the patient will develop severe dehydration and ketosis, hence what we know as diabetes ketoacidosis. So these children literally will present with that typical 4Ts, or in Bahasa Melayu we say 4Ks, kerap haus, kerap lapar, kurang berat badan, and kerap ketandas. Okay, so the thirsty, toilet, thin, and lethargic and tired. Okay, they are also very tired in this group of children. Okay, so the basic principle is still the same. It's insulin deficiency, hyperglycemia, and dehydration, and acidosis. Okay, despite knowing this for many years, right, we have a lot of issues in terms of diagnosing DKA, unfortunately. So we were hoping that with, long these years, 100 years has passed by, let's not talk before 100 years, we still are missing DKAs. We are still missing the diagnosis of DKA in children. So, and it has not reduced over the last 20 years, despite the evolution of knowledge in children with type 1 diabetes. And majority of them are happening in children lower than 5 years old. They present with severe DKA. They may even come in, and one of the commonest deaths of children with diabetes. Okay, and the worst part is that as we know a little bit more, DKA can actually also happen in children with the diagnosis of type 2 diabetes. So the although the objectives remains the same, the management of DKA remains the same. Correct hydration, don't overdo it. I'm saying the same thing. Correct acidosis by giving adequate fluids and hydration. Correct the hyperglycemia by giving insulin infusion, not stat doses of insulin. After fluid resuscitation, and eventually we have to switch off the ketones and transition to subcut insulin. There are still lots of mismanagement in terms of DKA itself. Okay, I shall not go into that because the DKA lecture is by itself a whole lot lecture, probably can extend up to a half a day lecture to just make people understand a little bit more about how to manage DKA. But what's new is that we need to understand that DKA in children can also happen with HHS. So it is very important for the young lecturers, young physicians to be able, number one, to detect diabetes in children, and number two, to be able to understand the concept of DKA and HHS, which can co-present in a similar situation. So therefore, the management itself slightly differ as compared to just pure DKA alone. Okay, right. So having said that, I'd like to highlight more on terms of the misdiagnosing type 1 diabetes. It has been shown before. I think this Munes et al., I think it was not long ago, 2015, but 4 or 5 years ago, has actually presented a nice paper to show that children with diabetes tend to be mismanaged. And I think I'd like to highlight this as much as possible to our to the public, as well as not public, healthcare professional, that we tend to take things for granted, especially in children. We think that children cannot get diabetes, so it's really wrong. So from that paper, you can see that majority of pediatrics, so you can see here, this is the pediatric diagnosis. Nearly more than half of these children are actually treated with flu or viral infection, or even a UTI infection at the first instance. And looking at this graph, it's simply just to show you that how neglectful we are in terms of thinking about diabetes, especially in children. So we can see that children who are younger tend to be misdiagnosed, and of course type 1 diabetes in adults is very rare indeed, hence they also tend to misdiagnose in type 1 diabetes in adults. What about in our population? So we published this, I think, about 2 years ago, and we have actually looked at all our patients who come in presenting with DKA in PPUM. Yeah, and interestingly enough, we are seeing almost something similar. These children came in with DKA, right? So we have at least about 70% of our type 1 diabetes presents with DKA here in UMMC, being it mild to the most severe DKA in UMMC. So when we look back at the history, when we ask the parents, where did you go? I mean, I went to this clinic, and they say, oh, this is just asthma. The second clinic came in again, oh, this is just AGE kind of thing. So they tend to be misdiagnosed. At the end of the day, because of that initial misdiagnosis, this patient presents with severe DKA. Despite looking at this graph chart here, majority of them, if you ask properly, they do present with actually polyuria, the osmotic symptoms, and polydipsia. And majority of the misdiagnosis was actually the respiratory causes and the gastrointestinal causes. So in summary, literally, what we can say that 1 in every 3 newly diagnosed, so that is a lot, children who are diagnosed with type 1 diabetes are actually misdiagnosed in our own population. We are not talking about, Sabah and Sarawak. I mean, they probably give a better diagnosis, hopefully. But here in the Klang region itself, 1 in every 3 patients are actually misdiagnosed. So that is something that I think in the next 100 years, even if I'm not here, even Prof. Yazid is not here, we do hope that a better pickup rate in the next 10 to 20 years down the line. We have also published this in papers and also in the, in a public magazine and with the help of Nadi, our collaborator, our NGO, to support or to educate people about the symptoms of type 1 diabetes. Right, so what do we know about the etiology? So let's go into the etiology now. So we know, majority of us would know already that diabetes in type 1 is almost always associated with antibodies, okay? So the most common antibodies are GAT antibodies, IE2, ICA, or I forgot to put in ICA, IAA, and the zinc transporter H, which is the new antibodies that has been found to be related with type 1 diabetes. But what I'd like to quickly highlight is that there is a genetic susceptibility in children with type 1 diabetes. So we know the HLA, the human leukocyte antigen genotype, and the highest risk are the specific genotypes that can actually contribute towards the development of diabetes. And there are also non-HLA genetic contribution, and they have actually identified up to 60 genetic variants that can contribute towards the development of diabetes. That includes the CTLA4, which I'm going to mention a little bit later, IL2RA genes as well. So in short, it's very simple. Individuals with first degree relative are actually at risk of an approximately 15-fold. So they have 15 risks higher to develop type 1 diabetes in their entire lifetime if they have first degree relative with type 1 diabetes. And if I'm not mistaken, the risk is higher in individual with identical monozygotic twins. It can be up to 75%. Correct me if I'm wrong, Prof. Yazid, is that correct? Yeah? Okay. So the next thing that we probably have heard, the environmental triggers. So we know we've heard before infection, we've heard before about nutrition that may trigger pancreatic beta cells. We know there's lots of papers looking at enterovirus infection and congenital rubella syndrome. However, the data is not very solid, and that's not much data to support CMV, mumps, influenza, rotavirus, H1N1. We also think that COVID might also trigger the susceptibility or the triggering the immune system in children with type 1 diabetes. So just to illustrate a very nice disease progression or stages of the development of children with type 1 diabetes. I think before this, in 2014, ISPED guideline previously uses the term PACES. It was just in 2018 that they produced this nice chart and pictogram to actually give us more idea about understanding on when this type 1 diabetes develop. We've got this question all the time from the parents. Why? Why is it my child develop diabetes at 5? Why is it that person dapat diabetes at 14? Why is it that person dapat diabetes at 17? We'll never know because the stages differ from one person to another. So, but what we know is that at stage 0, so this is all stage 0 at starting point. So if you already have a genetic risk, you have a higher risk of developing type 1 diabetes. And then the immune activation, by what I have already discussed with you earlier on. and a development of immune response within the person system. Okay, and eventually it goes into stage 1. Stage 1 is considered it's called stage 1 when you have the antibody. So you can see that there's 2 positive antibodies at least that has been triggered in this particular person, but with normal glucose tolerance, means normal glycemia and asymptomatic. As the time goes by, okay, the autoantibodies cause an impact glucose tolerance still within acceptable range, and majority of them are still asymptomatic. This is still stage 2, and development of clinical diagnosis. The true picture of diabetes is when they develop stage 3. So we don't know how long this is going to occur, but some of the studies have actually shown that for children who develop type 1 diabetes before their pubertal age, the time frame has already probably about within 5 years of this whole thing starts to trigger. So you can see we'll never know when that particular child is going to go to clinical diagnosis. All right. So I had to add this particular 2 more slides last night because of Prof Yazid. We went to DAC, Diabetes Asia Conference yesterday, and Prof Yazid gave a whole long lecture on the future direction and anticipation on what are the studies that are going on at the moment. And I don't think I can compete with that. But what I can do, trying to summarize what he has taught us yesterday in the Diabetes Asia Conference lecture, is that there are lots of studies, okay, not just recently, but probably about 40, 50 down the years, that looking at understanding the stages of diabetes and understanding what we can do to actually prevent type 1 diabetes in children. So starting from primary prevention, it was a long time ago when they looked into the possibility of cow's milk allergy that triggers. So we call it as primary prevention before even the development of antibodies, so at stage 0. Okay, so the trigger study has done something, to a group of children to avoid them from getting this early cow's milk exposure. However, there's no positive outcome. Same goes to the baby diet, looking at prevention or reduction of gluten use in babies and infants. A nicotinamide study looking at secondary prevention, so meaning that there are probable some autoantibodies has already developed, but to prevent the development of clinical diagnosis. So at the stage, we call it at stage 2. That's why we call it a secondary prevention. The oral insulin has also been, proven in vitro. However, and also the nasal insulin in the DIPP study. However, none of this study really gives a solid answer or solid reason to say that we can do this very early on. What about tertiary stage? Meaning that they have already had some sort of clinical diagnosis of diabetes, and to avoid further progression. There are so many studies looking at immunomodulation, looking at the C-peptide, whether we can do anything about it. Monoclonal antibodies, looking at rituximab, CTLA4. Remember, I mentioned about that genetic susceptibility. So abatacept, and also there's another one, I can't quite remember what is the other one. Professor Adam mentioned yesterday, couldn't find that paper, but abatacept is one of the example. However, these are all looks promising. However, it's not yet quite into the clinical picture. Interestingly, it was just about 6 days ago on 17th November, something that's very personal and very precious to Prof Yazid, because he was also involved in this study, looking at anti-CD3 monoclonal antibody, the teplizumab. Yeah. So the majority of the study was actually done in US, and finally FDA has actually approved this particular medication, teplizumab, which was actually given for 14 days infusion, and they look at the outcome of these children over 1 year and 2 years, and they have seen a very good outcome in delaying the progression of diabetes, both in the secondary stage prevention and also at the tertiary stage as early as 6 weeks after diagnosis. So it's very important to be able to do this in young children, and I think we are very hopeful that there's something like this will come in soon in Malaysia. I tak tahu, Prof, bila nak masuk Malaysia. I don't know. It probably is going to be very costly. But, something is there, something for us to hope in another 20 years, maybe 50 years down the line. Okay, so let's move on to insulin evolution. So majority of you would already know The insulin was actually discovered in 1922, and Professor Bunting and Bess from Toronto has actually initially purified from the dog. And then in 2022, they purified from the cattle insulin and given it to the first human with diabetes, not first human with, given first to the first person with diabetes to be given human insulin, purified insulin, and Leonard Thomas actually received this and survived the ordeal. Before that, children just died and passed away because of severe insulin deficiency. So we have gone through a long way, and I'm proud to be able to be here 100 years from the very beginning. I cannot imagine. I remembered my dad talking about and taking insulin. I remembered him extracting insulin from these little bottles and teaching people on how to give a mixture of insulin to give in patients with diabetes. It has gone, long way, and now we are in the quite an advanced stage where now insulin can be given through insulin pumps, and not just type 1 diabetes. I know that my adult colleague are also using insulin pump for people with type 2 diabetes because of the convenient and the easy method of delivering insulin in this group of people. Okay, what about other things? My children with diabetes would always ask, don't we have any other options? Please, we do not want to inject. So of course, this has been taught before, and there are studies looking at inhaled insulin itself. Okay, so the Exubera, the Frieza was actually approved way back in 2012, 2014. However, because of the poor variability, it's like, the one that you use for asthma, you can see the contraction there. And it's not quite popular, and the control was not quite good. So it was actually discontinued despite them going through phase 2, phase 3 kind of changes in this technology. So there are still some more studies reporting after 2016, but so far nothing much really. So we'll just hopeful and see whether it's gonna come back again later. Who knows? The young generation, young medical students who are very enthusiastic, very clever scientists can come up with something like this in the next 100 years or so. I'm hopeful. What about pancreatic transplantation? Well, we know that the issue with graft versus host disease, immunosuppressant, but in the recent, I think it's also in November this year, that the Endocrine Society has also released a press release conference to say that there is a hope in pancreatic transplant. The idea now is actually, last time it used to be a cadaveric transplantation, but now I think they're looking at transplanting a living donor into the patient with type 1 diabetes and keeping their own pancreas in situ. So meaning that they don't remove pancreas and put in the a dead person organ. So sounds like it's getting better. The technology is probably improving. Let's hope in 20 years down the line, this is also something that we can consider in our patients with type 1 diabetes. What about blood glucose monitoring? I had fun looking into this, preparing, although it was stressful, but I had fun doing this lecture slides, trying to look back into how long have we been monitoring blood glucose. And it seems that it has been way back from 1500th century, even earlier than that. And during that time, in the 1600th century, the early days, it was all about tasting the urine. So they have actually, prepared this what you call urine. I can't find the word, but this urine wheel to say that, okay, this is sweet like honey, because at the end of the day, diabetes mellitus means like honey. Okay, it's sweet like honey. So the taste of the urine, for God forbids I'm going to ever try to taste any urine, it is very sweet like honey. So there are different categories of sweetness. So therefore, they have created this wheel to describe the sweetness of urine in a person with diabetes. Eventually, they developed the Benedict solution and the effervescent clinical tablets, and the first urine test strip was actually discovered or presented or in service in 1956. And then we move on, because at that point of time, to do that urine dipstick was actually quite expensive. They are looking at a more cheaper solution, looking at dextro stick. So I think this is where we get the dextro stick. Every time we say, hey, dextro stick berapa? It's because of the initial development of this blood sugar testing in 1964 by EMS. And eventually you can see the evolution to try and develop something very simple, very portable, to be used at home for continuous monitoring, the sugar monitoring at home. Now, I hope you have heard about the concept of CGM, the continuous glucose monitoring. It was actually, the idea was actually in the mid 1990s, looking at the, that they have built this watch to be able to monitor glucose. However, as the technology improves, now we are even actually at the 4th generation of the Medtronic continuous glucose monitoring. And not just Medtronic, of course, there are other types and other brands of continuous glucose monitoring available in the world. And it can literally talk to your phone and tell you what is the sugar level, even without pricking the hands to look at blood sugar. And of course, we are, because of the cost, and also usually for continuous CGMs, they are about 5-7 days. They have also built another fantastic development of intermittent CGM, where you just need to flash the reader over the sensor. You can do it 20 times a day, and the chart will eventually be plotted in the system to see how well the sugar control in that particular patient. So we are very much looking into this to reduce the need of frequent pricking in children with diabetes. However, as you are aware, the cost, even for strips, are not covered by our government. Unlike our counterparts, unlike our the Caucasians, the UK and the US, they are all covered by insurance. But in our country, these children have to buy their own strips, and it's very expensive. It can go up to 150 to 200 nowadays. And the ketone strip that we use for sick days are also very expensive. Even if you ask me to buy, it's also pretty much expensive for doctors, really, with diabetes. And I'm pretty sure us, and anyone with diabetes, even we are doctors, we are also trying to cut the cost as much as possible for not checking our blood tests. We hope that in future we can try to cut down on the cost. We are aiming for funding. We are looking out for funding. The NGOs are helping us a little bit more, hopefully now, and hopefully in the future they can continue to do so. CGM to reduce pain, it's very expensive, need calibration, especially the CGM, the one that I showed you earlier. Freestyle Libre is also up to 500 ringgit a month. And with the technology coming in, insulin pump, you're closing the loop. We want to use analog insulin, CGM, intermittent CGM, glucose suspension technology that is so clever to even detect low sugar before it happens. And bolus calculators and downloading all these technologies are super expensive. This is where we are heading in the next 100 years. So I think we need to prepare our team. We need to prepare our stakeholders and our world, our country, to be able to follow this trend, to be able to follow this evolution, and not going back 60 years and continue giving mixed start, insular start for our patient. We have to stop this. We've got to be able to push for newer medication. The adults are getting 20, 30 new medications. Every year we have new medications for the adults. We need to fight for the same thing for the children as well. Children, we just need insulin. And yet it was still very difficult for them to get this. Even in PPM, it is free for children under government school. However, for the younger ones who haven't even started schooling, the parents have to pay for insulin. So I think we really need to look into this and see what we can help these children. Okay, my last few slides. What else do I want to highlight in terms of challenges? Okay, for in particular in this slide here, we know that the incidence differ from country to country. And in Asia, it's relatively low. Yep, that's quite true. But do we have the numbers? The last time we had some numbers was when Prof Yazid asked in the group, our pediatric regional group, endocrine group, hi, can I know some numbers, please? Okay. It's very to say, I'm sort of like a bit embarrassed to say that if all of you ask me, so what's the incidence of type 1 diabetes in Malaysia? I cannot answer. It's because that we do not have a proper registry here in Malaysia. The last registry which was set up in the early 2000 was actually stopped in 2009 because we don't have any more funding to help to support to maintain that registry. And at that point of time, I think we have also a lack of support from general physician around Malaysia to report new cases. But I think now with the awareness, I think we can continue to provide new numbers. And we hope that the new registry that was developed by KKM, I think we sat on this, Prof. Yazid, was in what, 2015 to 2016. We've already built up a new registry, and yet because of funding, it has always, COVID lagi, so all the funding goes elsewhere rather than to set up this registry. We hope that's now restarting. We are now getting some information that is going to start soon. I can give you numbers by next year. Should I have to present again on type 1 diabetes? Sorry. So last but not least, our other challenges, despite we think that diabetes is quite easy, it is not really. And I'm sure my adult counterpart, also will probably be saying type 2 diabetes in adults. 1 in every 3 or maybe 1 in every 5 adults in Malaysia have diabetes. There's so many people around us with diabetes, and yet it is not easy to manage. Okay. In children, it's even worse. We don't really talk to them about, nanti kena potong kaki, nanti buta. We don't talk to them about that at all. What we try to do is just convince them about quality of life. We want them to be normal as possible on top of doing things. Like you and I, all of us have children at home. We have teenagers, especially teenagers. Oh my God, they have mood swings and things. Having a normal teenager, normal without chronic disease, you can imagine how difficult it is for them to go through day-to-day challenges. Having a child with diabetes, it's double double whammo, we call it in this group of children. So for us to be able to say, I want HbA1c of 7.5 because UMMC is an excellent center of excellence, is complete bullshit lah, complete ignorance. We won't be doing that. Of course, we want good numbers in them, but at the end of the day, we want them to be happy as children. We want them to achieve normal development, normal growth, normal puberty, gaining weight nicely, and to have a normal psychosocial development. We have a group of children in this category who is suffering from mental health illness, and it's not easy. It's not easy for us, not easy for them to be able to cope this, and we want to avoid this as much as possible. They are at risk of getting depression, anxiety, psychosocial distress, eating disorder. We were just talking about it yesterday. Professor, I just remember I talked to you about the Dr. Luqman was talking to me. Dr. Luqman was our previous endocrinologist here in UMMC. He's now in Regency Johor, and there's no PITS endo in Johor. So they refer to him teenagers with type 1 diabetes. And this boy was only 14 years old. And guess the weight? The weight is only 20 kilos. That is way bottom bit. I can't even calculate the BMI now. But he is so scrawny and so thin. It's because they try as much as possible to avoid insulin injection. They don't want to eat because they know they had to do insulin injection. So the idea here is already, the concept is already very wrong, because people tend to say they know about diabetes, especially the adults. Public, I mean. You ada diabetes, you tak boleh makan. You tak boleh makan ni, tak boleh makan tu, tak boleh makan ni. Okay, which is completely wrong. In children with type 1 diabetes, they need to eat, they need to grow, they need to be normal. You cannot make them restrict their diet. So there's a lot of things that we need to do. We need to educate, we need to give that public awareness. And the only way for us to be able to do this, to support these children 100 years down the line, we still need to educate. We still need to give them that opportunity. And the only way for us to be able to do this is to build rapport, support them emotionally, while they grow up and become an adult. It's not easy, but this is just my last slide, just to share with all of you what our team, I'm blessed with our team. I'm blessed to have Prof. Yazid, our Prof. Fatima, who actually helped us a lot to understand about children with diabetes. I'm blessed to have been able to follow my dad all these years, even when I was little, to follow him around in diabetes camp. So last time diabetes camp used to be a combination of adult and children, but now we are standing on our own. UMMC, HPJ, they have their own diabetes camp. Profu last time in HUKM, they have their own diabetes camp to support children and teenagers with type 1 diabetes. So 100 years, I think it's a blessing. So what do we want? What do I hope? What do we hope in the next 10 years? I'm a bit sort of like to say ambitious to talk about 100 years. Let's just focus on the next 10 years, 20 years, maybe free strips, free lenses for these children, to be able to advocate more centers in Malaysia to, for physician, even if we don't have peds endo, we've got very limited peds endo. We've got 25 prof in Malaysia at the moment. Yep. Only 25, a majority of us are in KL. We hope to have more centers advocating for knowledge and taking care of children with type 1 diabetes. We hope we can have a free needle-free insulin in the future, pancreatic transplant, and of course, to be able to give them that painless CGM blood glucose testing, that privilege to our young children. Thank you.
Thank you very much, Prof. Yanti, for that excellent talk. Try to look into the evolution of type 1 diabetes in half an hour is rough job. Thank you very much for being able to look into the new development in prevention, in insulin delivery, as well as the blood glucose testing. And I believe these are the points that we need to put it up, hopefully, to the new minister in looking into the social welfare, I would say, of our type 1 diabetes patients. And when we talk about evolution of diabetes, we talk about finance, we talk about money. So I've yet to see any question. Let me see whether there's any question here. All right, so Prof, from Prof Chan. Ignorance of the metabolic consequences of DKA is not limited to children. As an expert witness, I see this occurring as a cause of death, together with dehydration it brings about in adults too. Could this be due to our endocrinologists not emphasizing enough of this in our lectures during their training? So what's your answer?
I cannot answer for the adult side, but from our side, I think we are trying very hard to be able to teach our young pediatrician, our young MOs about the importance of DKA. We even teach them in our session before they even come into pediatrics, when they have even the interest of DKA. Yes, but I suppose I do agree with you that I think we need to do more education. It has, we have lots more. We are at the top bit here. We have lots more newer generation of doctors coming in, and I think we need to be able to fully support education. And I think it's just work that has been at the moment overwhelming. I mean, I was just telling Prof. Yazid, we need help, we need staff, for me to be able to do research, because at this moment it's just education, it's just giving lectures, clinical services. So we do need more staff, we do need more people to be able to do this, and somewhat a better distribution. What do you think?
I think a lot of it got to do with education of our community, the parents, the community, and educate our HCP. I mean, I remember probably 10 years ago or more, I used to go to the ED and give talks to the doctors in ED on how to manage DKA in children, because we know that we cannot overdo the hydration. That can easily cause them to have cerebral edema, and we specifically put that into our guidelines. The next question from Prof. Chan is, do young diabetics have a shortened lifespan? How long have we kept registries of them nationally and internationally to be able to answer questions like this?
We don't have our own registry, but we know that people and children with type 1 diabetes are, of course, at risk of developing earlier complications. I think the key point is to get, I don't think we have any data here in Malaysia, right, in terms of lifespan in children with diabetes. But we know that they can. We've got type 1 diabetes who's 70 years old in the adult population. Going through many years of enduring many years of diabetes. But no, Prof. Chan, unfortunately, we do not have that data. But the lifetime sort of survival has increased tremendously in the last 20 years. That is what I can say.
Yeah, thanks. I think this is unfortunate that we have to prematurely stop our registry way back in 2010. But hopefully in the next 1 or 2 years, we're gonna, reactivate or make it better in our registry. Based on the international data, the DCCT study, which look at the intensive insulin versus the twice a day insulin, and a follow-up study of EDIC study, they have shown that if you were to manage them properly in a very early of their type 1 diabetes, they should be able to live like normal.
Normal person.
They should be able to avoid all the complications. And even in the US, they have a group of people who are above 50 that they call them the gold medalists. These are type 1 diabetes above 50 years old. That means that they can live long with the not so good evolutions that you see just now, right? These are the people who had to do a lot of more difficult injections and poorer insulin. I mean, less analog, less blood sugar check way back 40, 50 years ago, and yet they are still living without complications. So with all these new evolutions that Prof. Yanti mentioned just now, hopefully we can, improve the lifespan of these type 1 diabetes patients, provided they do what they need to do. We do what we need to do to improve their metabolic control and maintain a good metabolic control during their lifespan. So,
I would also like to actually comment that we are now at the moment trying to get as much as adult endocrinologists who are interested in managing young people and adults with type 1 diabetes. I mean, their focus, even in DAC, we can hear the topics and talks. Majority are mainly on type 2 diabetes. Of course, that's their biggest clients. But I think if we can try to find adult endocrinologists who are really interested with type 1 diabetes, going through transition, going through adult years, and getting that information, Prof. Chan, whether they live longer, whether they develop a complication, we are working hard on that. So hopefully, I know like Dr. Lokman last time and Prof. Alex last time used to be very interested in this group of people, but now we are seeing more newer generation coming in, and I hope Dr. Lim and Prof. Lim would also take over and looking into the interest of this group of people once they are in adult services.
Yeah, we are now trying to reactivate the type 1 diabetes registry, not just for children, but also adults, and hopefully we get a buy-in from the adult endocrinologists when we talk about registry for type 1 from the start of the disease till the complications and the mortality. So at least we have that kind of lifespan kind of registry. Hopefully that get a buy-in from the stakeholders. So I believe this is all the time that we have. Thank you, Prof. Yanti. I think we have exceeded some time.
Thank you.
Thank you everyone for listening. Thank you everyone for the questions and your interest in understanding type 1 diabetes in children. Yes, the percentage of diabetes type 1 in Malaysia is small, probably just about 5 to 10%, but the complications and the difficulty in managing them, I would say, supersede the numbers, and that actually need a lot of time, need a lot of effort from us, the healthcare providers, in helping them to go through their day-to-day life with needing to give themselves insulin to stay alive. Thank you very much, everyone. Hope to see you next time. Thank you very much. Assalamualaikum.
Assalamualaikum.